Hi, I'm Sylvia Chang. I'm the radiologist. I know most of you. Welcome to this morning's Urology Grand Rounds, and it gives me great pleasure to introduce this morning's speaker, Dr. Richard Cohan from Michigan, where he's professor of radiology in the Department of Radiology, University of Michigan Healthcare System. He's also, associate chair of education in the Department of Radiology, as well as associate program director. Dr. Cohan started on the East Coast, went to Harvard, obtained his Bachelor of Arts, and then he did his, obtained his MD at NYU and also did his residency there. He did abdominal and interventional fellowship at Duke, was on staff there for a little while, made his way up to Virginia and eventually to Michigan, where he works with Dr. Reed Dunnick and Dr. Jim Ellis, various other famous GU radiologists. So as you can tell, his expertise in GU radiology, everything from contrast agents to CT urography, as well as imaging renal cancers, which is what he's going to talk about. He's author of over 100 publications, over 20 book chapters, editor of 2 book chapters. He's been past president of the Society of Uroradiology, I think back in 2005, 2006. And he's also a member of the ACR on the committee in charge of contrast agents. So without further ado, it gives me great pleasure to introduce Dr. Richard Cohan. He's going to talk about imaging of renal cancer, staging, and after treatment.
Thank you, Sylvia. You know, I can't believe you remembered all that. I can't remember what I had for dinner last night at my age, but it's pretty impressive. So I've been in Michigan for 18 years now. My hair's all white now, so I guess I've been around a long time. And I was trying to think of the number of times I've given grand rounds to the urologists at the University of Michigan, and I think the number is 0. But I see the urologists every week because we have a urology oncology conference and have lots of interactions, but nothing formal, I don't think. I've talked to their residents sometimes and shown them cases. So it's always a little bit tricky or interesting to me to what to bring to show urologists. I have to be a little careful, I think, make sure I don't say anything too controversial. And also what I think that you would be interested in. So I'm just going to show you a few things that I think have come up a little bit recently. I'm going to start with, I gave a list of talks, I think, originally, of which this was the one chosen. And with a few things about staging of renal cancer, a few imaging examples, and then get into some of the postoperative issues, which I think nowadays are interesting and have changed given the use of partial nephrectomies now, which are so common. And a little bit about chemotherapy, although that only really tangentially obviously would affect urologists. Disclosures. I'm a co-investigator without pay on a research project funded by GE Healthcare. This is another long story which I won't go into too much, but I'm a consultant to some law firms representing GE Healthcare in ongoing litigation. I sometimes feel awkward in social situations, and that's it. But that third one is probably the most significant. What am I going to talk about again? A little bit about the accuracy of CT and MRI in staging renal cancers with some examples provided. And then a little bit more on post-treatment imaging, after thermal ablation, RFA or cryo, after partial nephrectomy, and after total nephrectomy, a few of the issues that come up. My hope is that this talk will be about 40 minutes or 45 minutes. I'm not sure about that because I'm too lazy and old now to time it exactly, but I kind of know approximately how long it takes me to say things these days. In terms of staging of renal cancers, are you guys still ordering IVPs, IVUs anymore? I would say now at Michigan, finally, we may do 1 a week, and they tend not to be referred to us by urologists. They're often coming from family practitioners or internists, and they order them, and we are still willing to do them, knowing, of course, that the yield is low compared to CT and the other imaging techniques that we have. So that's why I wrote, what is this study now? I think it's going away. I would say sometimes our urologists order them if they want to look at the upper tracts or before a nephrostolithotomy, if they want to just get a sense of the anatomy, but it's very rare. And for the first time, we have radiology residents who are finishing our residency who have never seen or done an IVP. which is just weird for me because 10 years ago we were doing them so often. So for staging, certainly, I think we would all agree that IVP never really had a role, and I think ultrasound has little role. Really, CT is the study of choice, but for staging, IV contrast material really needs to be administered. So if there's some reason why we can't give IV contrast material, we have a problem in terms of the accuracy of staging. And the same is true for MRI. It's really the alternative study of choice. It's a little harder to get, at least for us, probably for you too, I would guess. Is that right? A little more expensive. If CT works, I would go with it. But also for MR, IV contrast material is really required for staging. So again, if there's some reason, and the biggest reasons are previous reactions or now kidney disease, chronic kidney disease, that we can't give IV contrast material, we're going to have a limited imaging study. Now the dogma is, and there hasn't been a recent paper on this that I know of over the last maybe 15 years or so, that CT and MRI have over 90% accuracy in staging, that they really do a very good job in staging of renal cancers. I found out probably recently, I'm embarrassed to say how recently, that I had the staging, the TNM staging of renal cancer wrong, which I was teaching blithely our residents for years, but apparently there was a wrinkle that changed over the last year that you guys probably know about, but I didn't. So I put it down here in a number of slides. We'll see it sequentially. Do you use the TNM system here, I would assume, is that right? Because I know our urologists are pretty much using only that now. So this was a 2009 change, and the little wrinkle is this sort of use of the insertion of the 10 centimeter cutoff for T2A lesions, over 10 centimeters being T2B lesions. And then this other change, which is that T3A disease is now extension beyond the renal capsule, including the ipsilateral adrenal gland and renal sinus, or invasion into the renal vein. And that used to be T3B disease, I think, probably 3 or 4 years ago, but is no longer T3B disease. And T3B disease is into the IVC now below the diaphragm, and T3C is above the diaphragm, and T4 is adjacent organ invasion. So here are just some imaging examples. This is a solid enhancing renal mass. It's a renal cancer on a CT examination. Really Cohan, just to show you the right kidney here. There's the mass. This is under 4 centimeters in size, and so therefore quite easily, this is a three-dimensional reconstruction on the CT urogram, CT IVP, of the same lesion, more of the IVP look. And this is a T1A neoplasm, and it's easy to make that diagnosis. There's no other involvement. Here's another patient. This patient has gross hematuria, and if you look at this mass, you can see it's a very heterogeneous solid mass here. Again, looks like a renal cancer for sure. It's fairly large. In addition, though, here's a little subtle finding. This is the inferior vena cava right here, and right behind it is the adrenal gland, and there's actually a mass in the right adrenal gland. So this tumor involves the adrenal gland and the kidney. Therefore, this is T3, should be T3A disease, and some arrows just showing the renal mass and the adrenal involvement. This was a Furman grade 4 lesion. There's the pathology of the kidney, and here's the pathology of the adrenal mass. So again, I think CT did a pretty good job in this patient who has renal cancer with adrenal metastasis. Here's another patient who has a large mass, and you can see that there's the mass. There's some nodularity that goes into the perinephric space, and quite obviously nodular. And I have another image coming up here, and you can see that sometimes we see stranding in the perinephric space, but these are enhancing nodules. So this is really, for all the world, again, we would say it clearly looks like the lesion, the masses, that there's been extension beyond the renal capsule, and we would call this T3A disease. Again, I'm not showing you all the other negatives. There's no invasion of the renal vein here, for example, which now, again, just the renal vein alone would be T3A disease, but nothing in the cava as well. So this is T3A renal cancer again. So once again, and just another example of how well CT or MRI would do in staging. Now, there is a problem which I just will mention, and look at this patient. You can see a very heterogeneous solid mass, or renal cancer in this patient, and then we have this stranding in the perinephric fat. And the issue is, this is probably more common than not. Is that tumor, is that T3A tumor, or is that just edema or collateral vessels and no tumor at all? And I have to say this is the problem that CT and MRI both have, and this is the limitation. Unless the extension into the perinephric space is gross, as in the last case I showed you, we can't tell on imaging, and I don't really even try, unfortunately. So this was T3A cancer when the patient went to surgery. But I think it just could have as easily been edema, vessels, and so forth. So that's a real limitation of both CT and MRI. Imaging has great difficulty in identifying capsular invasion of tumor into the perinephric space unless the invasion is grossly obvious on the imaging study. There is one study from the Journal of Urology, and this is actually from Michigan, in which the study claimed, and it's just one study, that it may not matter that much because if the invasion is subtle and microscopic, it doesn't have a huge effect on prognosis and may not affect the surgery that much. Is that true or not? Do you guys disagree with that?
Well, based on what we were saying, it probably doesn't matter.
Okay.
Prognostically, you're going to get that.
Okay. So the comment I'm supposed to repeat, I think, just to say that in case there's anybody watching anywhere else, that it probably doesn't matter, which was my impression also. But just to say that if we tried to stage it, we would have this one limitation. So here's another patient. This is a coronal MRI examination. Again, it has to be done with gadolinium. Here's the liver. You can see here. Here's a large heterogeneous mass that's almost replacing the entire kidney. Here is tumor thrombus going into and expanding the IVC. So this is clear invasion of the IVC with tumor thrombus, and therefore this is T3B renal cancer. And again, this is where CT or MRI would do a very good job. And then I don't see this very often. This is one case where the renal mass, which you can't even appreciate it on this image being renal, left kidney, is actually grossly invading into the spleen. Pretty rare T4 tumor. I don't really have encountered this too much where there's been local spread, but it can happen once in a while. Again, we're pretty good with lymph nodes, and this is a patient who has a big lymph node behind the inferior vena cava, which is sitting here. And there's the mass, again, in the kidney. Very obviously, there's no involvement of the cava here, but obviously, huge necrotic-looking lymph node. And here's another patient. This is for N1. This animation is coming up in an odd fashion, but that's okay. This is M1 disease, and there's the mass again, which I've outlined. And just so happens that one of the distant metastases shows up on the very same image. Doesn't happen all the time. This is just fortuitous. You can see the lytic bone lesion in the lumbar vertebral body. So the bottom line here again, just to repeat, and I'm suspect I'm telling you nothing that you don't already know, that CT and MRI, as long as you can give contrast material, is still very good for staging, with that one caveat that spread outside of the renal capsule is difficult for us to identify unless it's really obvious. Now, I want to move on to what I'm going to give the bulk of this talk on, which is post-treatment imaging, because to me, I just find it interesting, and it's changed a little bit over the last few years. So I'm going to talk a little bit about thermal ablation of tumors first, sometimes done for T1A tumors, that in non-operative candidates in particular. I know our urologists have this whole discussion when we talk about the hereditary cancer syndromes, VHL, for example, whether to do thermal ablation on some of these patients. All of a sudden, we have the option of treating cancers that are really small, maybe 2 centimeters or 1 centimeter, rather than waiting for them to get larger, 3 centimeters, and so forth. But then the issue is, you do a thermal ablation, there's all sorts of scarring around the mass and the kidney. Does it make it easier for the next time or not? If you ever had to go in and operate on that kidney after a thermal ablation, would it be harder subsequently? And I think some of these issues about how to treat these multiple tumor patients are still unresolved, and it's an interesting dilemma. It can be formed to preserve renal function in some patients with chronic kidney disease, which is certainly an occasional problem. Following patients after radiofrequency ablation, I don't think this is really well defined as well. We tend to get an immediate post-ablation CT, and many places do that. And then we go on this frenzy of follow-up imaging. And this has been, I think we've eliminated the 2-month CT. I'm not sure about that. But this is what we had been doing. Post-operative CT at 1 month, 2 month, 4, 8, 12, and then every 6 months. That is a huge amount of imaging, a tremendous expense, but clearly we're in a new situation here, and the patient could recur. For most of the time, the recurrences, if they're there or if there's residual tumor, it's within the first year. And that's why there's this flurry of very rapid imaging. But is this too much imaging? I don't really know the answer to that. It may be. It's a lot of appointments for this poor patient to come back so many times. If there is residual or recurrent tumor, then the patients are reablated often. Once in a while, they even have to go to partial nephrectomy. How is the follow-up imaging done? Well, non-contrast images need to be obtained because if there's something that's high attenuation on CT or high signal intensity on a T2MR or high T1 signal intensity, we have to differentiate that from enhancing tissue. So we need, when we subsequently give contrast, so we need non-contrast images and then some kind of early enhanced images and then delayed enhanced images to look at the collecting system. And I'm going to show you some examples in a minute about what a normal post-ablation patient looks like and what some of the things that we look for look like as well. So after successful thermal ablation, in the first 2 weeks to 6 months, there's usually a thin rim of enhancement, actual enhancement, but very thin, between the ablation bed and the renal parenchyma. And this may be some kind of benign physiologic response of adjacent non-ablated tissue to the ablation process. But no other enhancement should be seen. Now, the ablation bed itself changes in size in most patients. In fact, usually after the ablation, the whole area gets bigger. So the ablation bed looks bigger than the original mass. And then it starts to decrease. And it goes down slowly, though. It takes, in this one series that I quoted, by 3 years, it's gone down by about 80%. But it's taken 3 years to do that. And in my experience, it never goes away entirely. There's always some residual abnormality there, which sometimes can be confusing. You see some fat invaginating between the ablation bed and the renal parenchyma and a little halo around the ablation bed and the perinephric fat. And I'll show you what I mean by those descriptors in a moment. So here's an example of a patient who had this little mass, and here is the post-ablation appearance of the left kidney. And you can see there's not obvious enhancement there, but the ablation cavity is larger than the original small little mass. And here's the patient 7 months later. And this is that little halo around the periphery of the ablation bed into the perinephric fat. And some of this fat also ends up invaginating deep to the ablation bed as well. And the only wrinkle I would say here is that if you didn't know, I made this mistake once, and I have not made it since. If you didn't know the story, you might think this patient had an angiomyolipoma. And as I said, I've made the mistake once, and then I realized my error. But these things look like little fatty masses sometimes that the patients end up with, and they stay that way. So knowing the history is certainly important. I have to also say that even if we don't know the history, now that I'm aware of this phenomenon, this looks just like an ablation bed, even though there is this rim of fat around the ablation bed. Now, MRI also has its distinctive appearance, which in many ways is just like CT. The only problem with MRI is we've got all these sequences that we can use that we don't have to worry about with CT. The ablation bed usually on T1 weighted images, this is a gadolinium enhanced T1 weighted image, fluid is usually dark. But there's this high signal intensity area here which is actually present pre-contrast as well, which is just a reaction after the ablation. And if we didn't get the pre-contrast images, we would not know that we would think that might be enhancement. This is a month, actually, let me go back a second. This is the pre-image, so I'm telling you the complete story here. This is the enhancing mass. This is 1 month afterwards without any enhancement, and this is what I was talking about with a 2-month post-RFA image, which is T1 weighted, and this ablation bed has very high signal intensity. After we give gadolinium, we could have mistaken that with enhancement if we didn't have the pre-enhanced images. This is 4 months later, T2 weighted image, again just showing the ablation bed. What does recurrent tumor look like? We look for areas that are persistently enhancing more than 2 weeks after the procedure. They're usually found if there's recurrent or residual tumor along the periphery of the tumor at the interface between the normal renal parenchyma and the ablation bed. They're usually nodular or crescent-shaped, and some studies have even suggested that microscopic foci, I guess this is no surprise, of tumor may not produce detectable enhancement even when they're there. In one series, almost half of the patients with a positive biopsy at 6 months had no abnormally enhancing areas detected on a CT and MRI before that biopsy. So the moral of that story was that's why the frequent imaging, because we keep waiting for there to be enough residual or recurrent tumor there that we can pick up the enhancement. So we bring the patient back a lot. Again, how often is the right amount, we don't know. If the ablation cavity after that initial increase still continues to increase, then we might have to worry about that ablation cavity as well. So here's a patient who's 4 months status post-radiofrequency ablation, and the patient had this little tiny enhancing nodule in the ablation cavity, almost ovoid looking, very rounded looking, and a number of us looked at this and we said, well, it's recently after the ablation, maybe this is a little pseudoaneurysm, or is it recurrent tumor? And there was a debate about what this was. Because of that debate, the patient actually went on and had an arteriogram, and there's no pseudoaneurysm. This is a lot of parenchyma that's just enhancing. This is a selective injection here. There's a blush of some of the parenchyma that's filled out, but there's no focal, round, arterially enhancing nodule on that arteriogram. And this turned out to be locally recurrent renal cancer after ablation. So we're looking for some area that really enhances quite briskly usually, when it eventually shows up. The patient went back, was reablated again, and this is the appearance of the kidney after the second ablation, no more enhancing nodule. This is a 30-year-old woman, 7 days after laparoscopic partial nephrectomy. I shouldn't have put this one in here, I guess. This was a mixed epithelial and stromal tumor, which is a benign lesion. And this is just an example, actually, of a leak. I guess I didn't have one after ablation, where on the delayed enhanced images, you can see some extravasation from the collecting system. So this is another complication of both partial nephrectomy and thermal ablation that sometimes can be encountered, but fortunately, it's pretty rare. Here's a 58-year-old man after a right renal radiofrequency ablation. This is a routine follow-up examination. And this is one more phenomenon that I just want to show you folks about. It's been sort of in vogue in radiology because it's cute. The ablation bed itself looks fine. Here, there's no enhancement. It's been relatively recent post the RFA, so this looks pretty good. But the wrinkle is what's going on in the bladder. There's a little, very low attenuation area up in the top of the bladder, layering. It's actually sitting on top of the urine. And it's fat density. So when we first looked at that, we thought, what's doing that? I mean, that's just totally unusual. And what that is, here's the fat fluid level in the bladder, chyluria. And this has been described after partial nephrectomy and after thermal ablations. And it's obviously some type of a communication that occurs between the lymphatics and the renal collecting system as a result of the procedure. It means nothing as far as we know. It's just one of those things to be aware of that it happens and to know why it's there. I would say in the past we didn't almost ever see that. Again, the results from communication between lymphatics and the remaining urinary tract. It can be seen after thermal ablation. It's also encountered in other conditions, including, believe it or not, filariasis, but we don't see a lot of those cases in the US or Canada. So it's just something to be aware of as a finding that has no clinical significance and not to worry about. Now, how about abnormalities after partial nephrectomy? I showed you a leak already, which is rare, as I said. Normal appearances, here's a case that I just pulled off recently. I think I knew I was giving this talk, so I looked for one because I don't usually save normal cases. But here's a patient, this was an unenhanced CT, who had a little mass in the left kidney, was a clear cell papillary renal cancer, which is a variant of papillary renal cancer now that's been recently described. And here is shortly after the partial nephrectomy. You can see a little inflammatory stranding. At the site of the nephrectomy, there's no abnormal enhancement on these early enhanced images. And then this was last month, again an unenhanced CT, but that stranding has even gotten a lot better. There's no recurrent mass there. There's some sutures material here. Pretty innocuous looking renal fossa after a partial nephrectomy. Here's another patient who had this little mass here, which looks very homogeneous and low attenuation. But this was a clear cell renal cancer, measured above water density, and the patient had a laparoscopic partial nephrectomy, had right flank pain 1 month after surgery, and had this CT. And this is a month later, and you can see that there's a fluid collection at the site of the partial nephrectomy and lots of little air bubbles in the fluid. Now, we in radiology, this is something that we don't know that much about. So this was read initially as an abscess. It's 1 month after surgery, he's having pain, he's symptomatic, fluid collection, gas bubbles. It could be an abscess. But the operative port was reviewed, and the patient had had Surgicel put in the operative bed for hemostatic control, and this was just related to the Surgicel. And the air stayed there for a much longer period of time. Now, we say in radiology that to see air on a CT scan probably more than 2 weeks after surgery is abnormal. And if you see air more than 2 weeks later, that almost always means infection. But this is an exception. So this patient had nothing done, no antibiotics. I don't know if the pain was related to the procedure. I don't know if it was ever explained. But the patient came back later, and everything had resorbed, and there was no mass, no fluid collection, nothing in the operative bed. So this is a wrinkle that it's important to be aware of. Here's another patient 6 months after laparoscopic partial nephrectomy, and you can see there's a little, I'm going to find my pointer here, this little low attenuation area. Is this a residual mass or a fluid collection sitting right in the medial aspect of the kidney? I guess those things are possible. This patient also turned out to have had a piece of Surgicel inserted during surgery, and that's all this little thing was. But these can be problems on imaging studies. So omentum was often packed in the operative bed after partial nephrectomy. Surgicel can be Oxacel and renal bolsters, and I'm going to show you a few examples of renal bolsters, one of which I made is another mistake I made. I'm going to show it to you momentarily, and that's just this oxidized cellulose that's used also for hemostasis. And these can mimic, as we've been talking about, infections due to persistence of gas in the operative bed weeks after surgery, or masses. And the only thing I can say is it's important to look at the operative note because it'll often suggest what the abnormality is being caused by. Here's a 65, this is the mistake I made. This was a 65, I only have to make these mistakes once and then I learn, usually, hopefully. 65-year-old man, status post-nephrectomy. This was the history. Follow-up CT to rule out new or recurrent mass. Okay, so this is the CT I was reading, okay? Well, there it looks like there's a mass in the anterior aspect of the right kidney to me. It's pretty homogeneous, it's pretty low, but it measured above water attenuation. Water is up to about 20. On the unenhanced scans, this was 32 Hounsfield units. On the early enhanced scans, it went up to 43. Well, that's about 11 increase. Is that enhancement or not? We used to say a change under 10 indicates that there's no enhancement. Between 10 to 20 is kind of a gray zone. We're kind of in that gray zone. So it's a little iffy. But if I'm supposed to rule out a newer recurrent mass on a CT, I'm a little bit worried about this lesion. Here was the original CT. Look at the way the tumor looked before the partial nephrectomy. Some components of it look very similar. There's some enhancing areas, but there also are some low attenuation areas anteriorly. So it doesn't help a whole lot, I don't think. Well, given what I'm talking about, this turned out to be a renal bolster. And had I not known, in fact, I didn't even think about it at the time, I made a mistake and I said, this looks like recurrent tumor here. But I didn't even think about the option that this could have been some surgical material. Now there's a little bolster. And here's another patient with a bolster who looks like they have another abscess because it looks like a fluid collection postoperatively. So again, I think this is solved usually by checking the operative note. Now there was a recent paper this year in the journal Radiology, which is our major journal, which talked about postoperative fluid collections after laparoscopic or open partial nephrectomy. And in this study, they found postoperative collections that could mimic an abscess or mass in almost 3/4 of the patients they included in the study. So it was much more common than not, including 90% of the patients who underwent laparoscopic and about 50% of patients who underwent open surgery. So it's more the norm than not to see something there after the procedure. So this is a new pitfall, which is kind of interesting. And interestingly, in the study, many collections lasted for a while. They lasted up to 12 months following surgery, with some lasting even longer. So the old days of knowing that a collection in the renal fossa is an abscess, for example, if it has air bubbles, a month after surgery are gone. If there's bolster, packing material, something put in there, then it could just be the normal postoperative appearance in that patient. Here's another patient. And you can see this patient had a partial nephrectomy for renal cancer. And I just have some tiny little Hounsfield unit measurements on this. It went from 10, which is close to water density, to 21, kind of an equivocal change again. Is this recurrent tumor? This was the tumor preoperatively. It looked larger, more heterogeneous. We reviewed the operative note, and this patient had a bolster inserted at the time of surgery again, so all we're looking at is the deformity after the insertion of the bolster. How big is the tumor initially? I guess, I think it looks like it's probably about 1.5 to 2 centimeters in size, I would guess. Did I say big? It was bigger. I'm sorry. Thank you. You're right. Should we avoid bolsters? I don't think so. I think the most important thing is just to be aware now that they can be confusing.
How many of those cases would have a recurrent cancer whose diagnosis is delayed?
How many cases would have a recurrent cancer where the diagnosis is delayed? I think the vast majority of time when I've seen these recently, they are not recurrent cancer. I think the vast majority, in fact, I'm showing you a whole bunch of examples here. Off the top of my head, I can't recall seeing a cancer that recurred after a partial nephrectomy there. So my assumption would be for most of these, as long as I could find confirmation in the operative note or talk to the urologist and know that something was put in there, I would say, let's get a follow-up study and make sure this continues to go away. In fact, I think I have a slide coming up that talks about that. Another.
We can talk about this in the discussion too, but the bigger question is, should we be actually treating a 1.5 centimeter lesion?
Well, should we be treating a 1.5 centimeter lesion? I think you're absolutely right. There's this whole issue now, and I know that I don't have the whole chronology for all these patients as to why the decision was made to treat some of these lesions, but there's no question if there's a 75-year-old man with a 1 centimeter mass, what are the odds that that patient's going to die of that mass? So I think you're absolutely correct. I don't recall why some of these very relatively innocuous looking cancers were treated. But I think that's correct. We're doing a whole lot to these patients, and then we'll treat them and get all sorts of follow-up imaging after that.
Post-procedure imaging is worse than the pre-procedure.
Yes, I would say so. So this is just a study that was published this year that talks about what we do if we have an equivocal mass that may be from a renal bolster, but it might indicate recurrent tumor, for example. If the lesion is decreasing in size, then we can be fairly confident it's a bolster or some postoperative material, and we're done. If it continues to increase in size over time in a follow-up imaging study, then we have to worry about tumor recurrence. And if there's no change, or the status of the change is unknown, then we have to get some type of short-term follow-up and make sure that it's decreasing, or at least not increasing. So as the questions indicate, it's an issue now, but I think, as I said, my own experience, most of the time these are related to packing material, as long as we can confirm that, and also show that these changes are getting better over time. Here's a 70-year-old man who had a right partial nephrectomy for a T3A renal cancer with chronic kidney disease. Here's the original MRI, and this is a T2 weighted image. You can see this was not done with IV contrast material because of the chronic kidney disease. These are diffusion weighted images, which are now done, that identify differences in diffusion and find that tumors have more restricted diffusion, and the tumor is actually showing up brighter because the diffusion is more restricted in that lesion. And here is the patient after surgery. The patient had a partial nephrectomy and had this little bit of stranding here, which was gradually increasing, and believe it or not, this was biopsied and turned out to be some perinephric recurrence. And this is one of the examples I have. It's very subtle, and if I didn't have comparison CTs, I would have thought it was just a normal post-operative appearance. But sometimes it can happen. So we certainly need to watch the perinephric tissue for changes over time. Here's another patient who had a recent laparoscopic nephrectomy for renal cancer. The CT was performed to rule out recurrent disease. I just threw this one, and this is pretty rare because it looks a little bit like that recurrent tumor after RFA that I showed you earlier. You can see this very enhancing area on the early enhanced images on the CT scan, and this turned out to be a pseudoaneurysm after a laparoscopic partial nephrectomy, or could happen after thermal ablation as well. It looks a lot like that little nodule of recurrent tumor that I showed you before. That's why there was some confusion about it. You could answer this question probably by doing an ultrasound or an MRI to prove whether there's flow in there or not. It doesn't require an arteriogram even. Here's another patient after a partial nephrectomy. There's the nephrectomy bed, probably with some packing material and other little fluid collection in there. We would expect it now, and I'm just putting this one in to show you again that cute little finding of fat fluid level in the bladder. It's chyluria. It doesn't mean anything, but we see it from time to time after partial nephrectomies as well. After nephrectomy, here's a patient with a large mass in the renal fossa after a total nephrectomy, 2-year follow-up. There was obvious local recurrence in the nephrectomy bed. We look for local recurrences or distant metastases or cancers in the contralateral kidney. Here's another man who had a partial nephrectomy for sarcomatoid renal cancer. This is cute. This one was missed by us for about 7 or 8 months. I should say it was probably over 2 or 3 CT scans post-op. It might have been longer. There's a recurrence in this patient. This was even missed as it got larger, but I'll point out the recurrence. It's sitting right here next to the psoas muscle in the quadratus lumborum area. You can see it right here. Somebody finally picked it up. Here's the little recurrent tumor nodule earlier on, 4 months earlier. Sometimes when masses are in the musculature, the subcutaneous tissues, they're blind spots for us as imagers. And we see this more often now, a lot of them, sometimes after partial nephrectomies too. I'll show you some more examples in a moment. It was biopsied and it was a recurrence. Here's another man who had a renal cancer in 1993 and fell from a tree. And this was the trauma CT that the patient had. And you can see that there's a mass in the, it looks like a mass or blood clot, something that's very bright on these images in the tail of the pancreas. There's two more areas in the head to body of the pancreas. So there was a debate about this. Is this a hematoma, or is this metastatic disease, or is this an islet cell tumor? So that was the differential, neuroendocrine tumor of the pancreas, which they look just like this. So the patient actually came back to see whether these got better or not a few months later, and they didn't get better. And this turned out to be renal cancer metastatic to the pancreas. Now, for some reason, renal cancer likes the pancreas, and I don't know why that is. Here's a study that was published in the journal, the widely read journal Pancreatology in 2008. Who knew there was a journal called Pancreatology? 29 lesions in 22 patients with pancreatic metastases, and 22 of those 29 lesions were from renal primaries. So when there was a pancreatic met in the study, it was most of the time from renal cancer as a primary. There were some others, some colorectal cancers and some other things. And the renal cancer metastases were often heterogeneous, often hypervascular, hyperenhancing, and in the paper they noted that you really can't tell them apart from pancreatic neuroendocrine tumors. But again, I have a whole collection of these, and my only motto is it's worth looking a little extra at the pancreas in renal cancer patients, because these tumors, for whatever reason, sometimes go to the pancreas. Here's a patient, this is a more subtle case, who the whole pancreas is expanded. In this patient who had a total right nephrectomy, you can see the right kidney is completely gone. The whole pancreas is expanded and a little heterogeneous. It was widely involved with metastatic disease. Here's another patient after a laparoscopic nephrectomy for renal cancer. And again, you can see the right kidney is absent. And this is, again, what I was talking about when for imaging blind spots for radiologists. This patient has recurrent cancer. The trocar site I have outlined. There's a little scarring probably in the abdominal wall from a trocar site. But there is a tumor nodule in this patient, which is not where we would expect to see renal cancers as we would have had we done them years ago with open nephrectomies, at least as commonly. Now, this doesn't happen a lot, but it happens sometimes. Here's a nodule right here. This is the IVC in front, which is pushed up by a lymph node. That's a little more common. But there's a tumor nodule in the anterior abdominal cavity sitting next to a loop of bowel. And again, those are harder to spot. The moral here, I think, is that we just need to look a little bit more along port tracts and sites like that for recurrences, because they're occasionally seen at those locations. Here's a patient who had a laparoscopic nephrectomy for renal cancer 1 year earlier. Here's a follow-up study. This was the original neoplasm. This was a type 1 papillary cancer. And here's an MRI that was done shortly, done a year later. And you can see in this patient, there are little tumor nodules, probably along one of the tracts again, just leading right out to the anterior abdominal wall. This patient had a cystoprostatectomy and a retroperitoneal laparoscopic nephrectomy in February of this year. And this patient had a little nodule in the back, which got larger a few months later. Now, we see buttock granulomas all the time, and they can look just like that first nodule. So it's a little bit tricky, but they don't get bigger like this patient's nodule got bigger. So again, my only comment is that we're now seeing disease in patterns that we didn't quite see it before. So we just need to be sensitized to that fact. We're not just looking in the nephrectomy bed anymore. We're not just looking at the retroperitoneal lymph nodes or at the liver, bones, and so forth. So this is just a study confirming that, which I want to try to finish in the next 4 or 5 minutes, which basically just talks about it's a case report, which basically I'm just going to skip to the bottom line here, which just says that the patterns of recurrence now are sometimes different from that usually seen after open surgery. Now, I just want to make a few comments about the treatment of metastatic renal cancer and some of the problems that creates for imaging. We have this whole line now of new drugs for renal cancers as well as many other cancers. The multi-kinase inhibitors like Sutent, sunitinib, sorafenib, everolimus, which is a mTOR inhibitor, Avastin, and so forth. And my impression is, and you guys can correct me if I'm wrong, is that it's certainly not curing renal cancer, but there are some patients who at least stabilize for a while on these agents, which is better than nothing. We have traditionally used this criteria called the RECIST criteria over the past 8 to 10 years now to track solid tumors. Our urologic oncology colleagues use the RECIST criteria. And what they do is they take long axis diameter measurements of up to 5 lesions, add them all up. The lesions have to measure each one at least 10 millimeters in size. You can include lymph nodes, in which case now we measure them in short axis diameter. You sum up all the measurements, and then you compare the sum from one CT scan to another to look for a response to chemotherapy. And the possible responses are a complete response, that means everything goes away, all the mets go away with treatment. A partial response, which means there has to be a 30% or bigger decrease in that sum measurement. Progressive disease, which means there has to be a 20% progression or bigger of that sum measurement, or no change at all, stable disease. And this has been a popular system that's been used for many solid tumors recently, and I know our urologic oncologists use it. The reason I'm bringing this up now is that there is a little wrinkle this is caused on imaging in these patients. Patients who are treated with some of these multi-kinase and mTOR inhibitors and so forth can have a different kind of response to treatment. Here's a patient in December 30th of ours who had lung metastases. You can see the lung mets over here, and had some retroperitoneal masses as well from widespread metastatic renal cancer. The patient was treated with these 2 agents, came back a few months later. The lung nodules are smaller, they're lower attenuation, and these retroperitoneal masses are much more necrotic looking. This is clearly a response to treatment. However, some of the lesions are smaller, but not all of them. Some of them are just necrotic. So the problems with the RECIST criteria is it only accounts for changes in lesion size, and lesions may respond to a chemotherapeutic regimen by changing morphology in addition to or instead of changing in size. We knew this for years because of Gleevec, which was used for GI stromal tumors. We're seeing the same thing now with other cancers after treatment, including renal cancer. Here's a 74-year-old man with renal cancer, was resected in 2001, has had an enlarging retroperitoneal mass since 2006, was placed on Sutent in September of 2009. There's the mass. This is what it looked like 10 months after the patient had been treated with Sutent, and you can see it's much more necrotic again. So what now happens is RECIST is not good enough anymore. We need another system that takes into account size changes and attenuation changes or enhancement changes on CT or MRI. So that system is not there yet. It doesn't exist. Now here's a proposal from one series, which I'm not going to go over in detail, but they suggested including size measurements and changes in attenuation with treatment to indicate tumor response. And they use cutoffs of 20 or 40 Hounsfield units. It's arbitrary. But suffice it to say, we're going to have to come up with something else. Here's just another renal cancer that became totally necrotic after treatment with a multi-kinase inhibitor, and but didn't decrease in size. So it clearly responded, even though the tumor didn't shrink. It came back again, but this patient was given some more time. The patient's tumor didn't even end up at the original size and heterogeneity until over a year after the treatment started. So this is just one study recently this year in radiology talking about the possibility that CT, by looking at the way that tumors enhance, might be able to predict how well they respond to Sutent or other multikinase or MTOR inhibitors. And again, I'm running a little bit late, so I'm going to go quickly over this. But suffice it to say, it may be possible with imaging to predict whether a tumor will respond well to a multikinase or an angiogenesis inhibitor. And that still is in its early infancy here, but it's possible. No one would accept this as dogma right now, but it's an interesting possibility. Interestingly, in this study, even though dynamic CT could predict responsiveness, there was no difference in survival, so it may not make any difference anyway. We don't know that yet. But CT may be able to predict response rates to anti-angiogenic therapy. Okay, summary. Again, CT, as I mentioned, and probably you all know that it's very good for staging except for this T2, T3A issue. Can we see capsular invasion if it's gross? Yes. If it's subtle, not necessarily, but it may not make any difference anyway. The treatment of renal cancer, it's important to know what happened at surgery because now we would expect more often than not to see something at the site of a partial nephrectomy. Remember also that metastatic disease now can have different appearances after partial laparoscopic nephrectomies when we can see tumor nodules that show up along the tumor tract, for example, in locations that we didn't see it before. And now also remember that lesions respond, metastatic disease responds to chemotherapy by shrinking sometimes, but not always, but also by decreasing in size. And we're going to need to modify our way that we measure metastatic tumor accordingly. We haven't done this by now. Well, I just ended with a joke slide. I found this birthday card, which sums my attitude about life up, I guess, which says I used to, well, you probably can read it. People say live each day as if it were your last, but if I did that, this is the way I would feel about it. So I don't tend to do that, hopefully. We have a few minutes for questions, not much, but thank you very much.